everyone, and welcome back to another insightful episode of MedSynapse podcast series. I'm your host, Hetri Shah, and today we're diving into a topic that is critically important yet often challenging, which is pediatric airway disorders, its evaluation and management. Airway issues in children can look very different from adults, and timely diagnosis and management are vital to ensuring good outcomes. And to guide us through this interesting and fascinating subject, we have with us Dr. Namrita Bopanna, a highly respected ENT consultant from Bangalore. With over 16 years of experience, she specializes in micro-ear surgery, nasal and endoscopic sinus surgery, head and neck surgery, and pediatric ENT care. She's a gold medalist in ENT and is widely admired for a patient-friendly approach and clinical expertise. So, welcome, doctor, and it is such a pleasure to have you alongside me today for this discussion.
Thank you. Thank you.
So, doctor, I'm so excited to hear your insights, especially on this topic, which is such a concern, especially in children sometimes. So, doctor, to begin with, airway issues in children can present so differently compared to adults. So, could you share with us what are the most common airway problems that you encounter in pediatric patients?
Yeah. So the pediatric airway, rather the going from the voice box, just above the voice box below that, the trachea, the breathing pipe entering into the lungs is generally smaller, shorter, much less in cross-sectional area, and much higher as well, prone to injury. And because of the anatomical challenges, a child usually will have a larger head-to-body ratio, will have a larger tongue, smaller upper jaw or the mandible. And because the back of the skull is also very protuberant, it tends, when they lie down, they tend to have a lot of neck flexion. So, because of this, any injury, any sort of swelling tends to cause a very quick compromise in the airway. So, compared to an adult, which is a very well known area relatively, this is a huge challenge. Head and neck is anyway a large challenge, even if it is not pediatric. This is an additional challenge. So we're always, scoping the area, making sure that we don't invade any tissues that are prone to injury. So we see a lot of, in very small children, we'll see a lot of laryngomalacia, which is basically a very softening of the tissues of the airway. Children, by and large, because they're young, developing, and the cartilages are very soft, it's already very soft. But laryngomalacia is an even more of an airway collapse. In older children, 1 to 5, you'll see infection-related issues such as croup, or you'll see bronchitis, all viral related. Bacterial infections are relatively less and also secondary to viral. And you'll see a lot of foreign body aspirations because they have a lot of allergy in the airways around that school entering age. And because of that, they will tend to, try and do something to mitigate the irritation they have. And so they end up putting stuff in the nose, in the ears, in the throat. And the challenge is before they aspirate or it enters the lungs where you can't take it out and it gets stuck and it has huge mortality issues, you would like to get it out. Older children, generally, it's related to infections. Again, rare in presentation because nowadays a lot of patients do see the doctor more quickly. So things like tracheitis or severe abscesses in the pharynx, the throat area, can cause challenges and airway compromise.
Yeah, doctor, that's really insightful. Especially what would I say, how these presentations can be subtle but so significant also. So now, doctor, now when a child presents with, stridor or persistent noisy breathing, so what's your approach to evaluation and what are the key steps do you follow?
So, see, stridor is a very monophonic sound which is produced largely on inspiration, but can also be produced when they expire. And this depends on where the obstruction is. So, when you have a patient in stridor, you're going to evaluate the severity first and foremost because a child who has significant sound but only at rest and is comfortable otherwise in all activities, you would consider it as mild. If the child has a lot more sound, and is also having it with the slightest, not able to do its normal functions, is having respiratory compromise, you would like to admit the child, especially if they're 1 year and below, and observe and investigate. Of course, severe respiratory compromise, you would intervene much earlier. And then also it depends on other parameters like the oxygenation and also the child's ability to thrive. So failure to thrive is a very key term that we use often, saying that not being able to, eat well, losing weight, not doing well. The child is not even able to perform normal mental capacities or physical capacities because they're compromised by their breathing. So intervention usually will be to secure the airway. Now, if there is any surgical intervention, then it is preferably, again, as I said, under hospitalization in an operative theater, and all other handling of the airway, etc., will also depend on what diagnosis we can do. So if the child is very unstable, you can't go in and put in an endoscope, and you will actually compromise things further. So the challenge is basically evaluation at that point and securing the airway and trying to get the child back to normal as soon as possible. Usually in significant moderate to severe laryngomalacia, subglottic stenosis, if the patient is having a lower respiration rate, as in below 95 and falling faster, then we would rather have to intubate the child for that time being, and with ICU support, pediatric, etc., then evaluate or intervene based on the case.
Correct, correct. I think that's such a structured approach that you've shared, and it's really necessary, especially taking care of the age also matters for these patients. So it's really a structured. So now, doctor, in that line of evaluation only, could you explain the role of laryngotracheobronchoscopy in diagnosis, diagnosing pediatric airway disorders?
Right. So generally, if we're doing a scope means to explore, and the usual instrument that we use most often is a flexible endoscope. So it is a very small diameter instrument with a lens at the end of it, with fiber optic cable, etc., through which we visualize the entire airway. So it will be something like 2.7 to 2.4 millimeters introduced through the nose, and we go all the way down through the portion above the vocal cords, through the vocal cords, what we call as supraglottis, glottis, and subglottis, into the trachea, into the bronchioles, and then we visualize the entire airway. So if it is only the upper airway, then it would be called as a laryngoscopy. If it is the trachea, then it is a tracheoscopy. And if it is a bronchial area, then it is a bronchoscopy. We do use rigid scopes, but that's usually with ventilation, where we'll have an anesthetist who is helping us secure the airway and ventilate the airway. And these rigid scopes are used also to diagnose, to intervene, perhaps collect samples for testing later. And if there's something like a foreign body, or maybe we suspect some kind of, say, like tuberculosis, we would remove tissue or remove the foreign body in the same setting.
Yeah, I think that really underlines its importance also. So, doctor, just a quick follow-up question that how has the diagnosis, and especially in pediatric patients, evolved over the past, say, 5 years?
See, the thing is, we're living in an age where there's a lot of rapid development. AI is coming in, scopes are being made more efficient, more accurate, and we have a lot of also image guided software, guided instruments like the ultrasound. We also, because when you want to do a surgery in the airway, you will do it endoscopically or externally or both. And so to maintain the airway after the correction is done, you would also use stents. Stents are generally, you do have 3D printed stents, you have ready-made stents. The 3D printing with various bio compatible materials is still in evolution. But there's a lot going on. Now, considering all this, hospitals, teams, doctors are constantly upgrading themselves. There are a lot of courses going on throughout the year where we upgrade ourselves and try and keep up with the trend. But ultimately, it is the patient the patient's individual problem, the variability of the problem, and the stability of the patient that determines how well we can apply these new advances to that patient. We generally go for tried and trusted things that will give us the best outcome, and we wouldn't want to experiment too much, especially in a child. That's the last thing you need to do. You need to be as secure the outcome as possible.
Correct, correct. Now, doctor, now when it comes to, congenital airway no, anomalies like laryngeal wedge, subglottic stenosis, or, tracheomalacia, what are the key considerations you keep in mind while managing the conditions?
Yeah. So now the thing is, we need some guidance, and this is from years of research. A lot of doctors have come together with classifications, etc. So again, coming back to the airway, we would follow something like mild, moderate, severe. Again, whether we can wait and watch, that's usually mild to moderate, and that would depend on the oxygenation. It would depend on the compromise of the air. So mild is essentially about 50% of the airway, up to 50% of the airway compromise, where at the most the patient has a change of voice, but no respiratory compromise. 50 to 75% would be a moderate, and more than 75% would be severe, where the patient has not only dysphonia, that is a change in voice or abnormal voice, but they also have respiratory challenges. So it's not absolute, these classifications, but based on this compromise, we decide what intervention to do. Mild to moderate, as I said, we wait and watch. We keep the patient as comfortable as possible. We optimize airway protocol, anti-reflux measures to ensure that the airway doesn't get irritated or inflamed due to reflux, which is very common in these children. And we would keep an eye on their growth parameters, their milestones, etc. So if they are improving with age, which does happen in airway Malaysia, so in my cases, they do improve over a period of, say, about 12 to 24 months. Earlier, we thought that anything beyond 6 to 12 months, no improvement would possibly mean intervention, but sometimes we even wait up to 1.5 years of age. You have these glottic webs, basically. They are remnants of when the fetus is developing in the womb between the 6th and 10th week of fetal life, embryonic life, where there's a lot of tissue that occupies the developing larynx. It's supposed to melt away, essentially get absorbed. And when it persists, that forms a web or a remnant of tissue between the two vocal cords. So that is essentially what a glottic web is. And you have your stenosis. Now, subglottic stenosis is a narrowing of the airway below the vocal cords. And this could be congenital, that means the child is born with it, or it could be acquired. Like if a child has very severe lung issues, then they would be ventilated. The tracheal tube might cause a thinning out due to pressure in that area or scarring. So either you get a malacia or you get a stenosis in that area. And the other thing, Malaysia, again, either the airway Malaysia, the child is born with it. And earlier, we thought it was an anatomical abnormality, but there's also some amount of neuromuscular reason behind it. So again, based on how compromised the child is, we take a decision.
Correct, correct. I think that balance is very important, doctor, I would say. Now, doctor,
Yeah.
switching gears to acquired airway problems, such as post-intubation, laryngotracheal stenosis. So, how do you usually decide between and surgical management?
Yeah. So as I said before, it depends on the child's compromise. So if child is having failure to thrive, difficulty in breathing, then we will wait and watch versus intervention. Intervention is usually taken after a lot of planning. So you will do ultrasounds, you will do we don't like to do CT scans too often in children because it's equivalent to about 40, 50 X-ray radiations in even the best machine. So you probably do MRIs. If you're doing a CT scan, we'll try and do it only one time. Because the bony configuration or the cartilaginous configuration is very important. Then you will plan your surgery. So surgery will depend on where the compromise. So if it's in the larynx and say the epiglottis is a small cartilage behind the tongue above the vocal cords. So if it is very curved, what we call as the omega epiglottis, then it might be covering the vocal cord area or the breathing area, breathing passage. So then we decide whether to do a laser release on either side, or again wait and watch to see if it improves. Usually that doesn't, and then you have to intervene. Then if it's a tracheomalacia, that's a more external approach. You do need to go through the chest, so to do what we call as an aortopexy. So that is where the tracheal portion is sort of hinged onto or attached to the aorta, so that it holds it open. And stents are sometimes used post surgeries where there's nothing you can do. You have to resect a portion of the trachea, which you'd like to keep to less than 30%. Then you would also do a end-to-end anastomosis, and you will put in a Montgomery T tube, just till the point where you feel the child is safe to undergo a decannulation. And once the decannulation is done, if there are 6 months of relatively no episodes, child is doing well, then you would consider it successful.
Yes, I think Doctor, that is like a good brief, and that actually makes so much sense also to me right now when you as you talk about it. So now, Doctor, finally, tracheostomy in children can often be challenging for both surgeons as well as their families. So could you walk us through the main indications, risks, and long-term care effects to keep in mind?
Yeah. So usually, when you require prolonged ventilation, so a child is not doing well, they have some bronchopulmonary dysplasia, or they have a lot of lung issues, especially, then their requirement for ventilation goes into days to weeks. Beyond the fourth, fifth day, you would consider doing a tracheostomy. Uh, then, if the child has some kind of mass, either pressing on the airway or in the upper craniofacial abnormalities, or there's a huge abscess, or there is probably some Ludwig's angina, something like that, where you know you can't intubate the child and you need immediate access to the airway, then you would do a tracheostomy. Other reasons for tracheostomy are if, as I said, lung issues where you need access over there. When you're doing a tracheostomy in a child, you have to plan again. So because the larynx is higher up, so you'll have more tracheal rings above the sternum over here. So you have to decide where you want to do the tracheostomy. You'd prefer not to do a very high one because that would actually cause what you call as iatrogenic subglottic stenosis. Okay, and so you'll go through the trachea. You have to plan. You have to be very careful not to injure the surrounding tissues, like the cricoid cartilage, or going into certain nerves like the recurrent laryngeal nerve if you're going a little below. So there are many considerations. Now, morbidity and mortality associated with tracheostomy in a child is much, much more than an adult. So something like in most research or papers, it says about 20%. And in about 3 to 9%, you might even have, if you're not careful about where you're putting the tube, how you're doing it, you can even cause what we call as emphysema, or you can cause a pneumomediastinum or pneumothorax. So this is essentially where excess of air has been introduced into the chest or the lungs. You can also cause a false passage with time. And the challenges of after tracheostomy are the care. Because if you're not careful, you can have erosion related issues like a formation of granulation. Around the opening of the tracheostomy is known as the stoma. So around that granulation tissue is essentially tissue that is formed in response to a healing process or an abnormal healing process. It can be excess due to irritation. You can even cause airway malacia due to the tube itself causing pressure necrosis. So there are a number of considerations: erosions into the surface, erosions into the esophagus, etc.
Yeah, I think that's such a practical overview, and also it really shows the holistic approach that is really needed also to treat anything,
You need a
especially the
multidisciplinary approach. Though it's difficult
definitely.
without a team. You need experience, more experienced colleagues. So there's a saying: it takes a village to raise a child. It
Yes,
takes several villages here. So
true.
in that scenario, ultimately the child doing as well as possible is the aim.
True, true. That is so rightly mentioned, doctor, and that really fits so well in the I think entire entire doctors community also. So it's really important. So, Doctor, thank you so much for sharing your insights today with us and your expertise, especially. And I think your insights into evaluation and management of pediatric airway disorders has been extremely valuable. And I'm sure our listeners will take a lot because I have gained so much today. So, thank you
Thank
for
you so
sharing
much
that, Doctor.
for the opportunity, and I hope I was able to, shed some light on the topic.
Definitely, definitely. And I think this is such an underspoken area where more light and more awareness needs to be shared. So thank you for doing that, so Doctor.
Yeah, yeah. Thank you so
And
much.
and to our listeners and audience, thank you for tuning into this episode. And remember, if you're a healthcare professional who is eager to delve deeper into medical topics or have questions, do not hesitate to join us on the MedSynapse platform. MedSynapse platform is not just a resource, it's a dynamic space where you can connect with your medical peers, participate in meaningful discussions, and contribute to the ongoing evolution of healthcare. So until next time, take care and keep learning.